Great. It was a wonderful session. Thank you for it, Saul and Carmel. It was wonderful to hear those speakers. So I'm Kathy McDonald, and I'm Bloomberg Distinguished Professor of Health Systems, Quality and Safety at Johns Hopkins University, and I'm a member of the Planning Committee for this day, and will moderate this session, which will provide an overview of some of the exacerbations that we've been seeing in inequities during the COVID-19 pandemic. Equity is quite inseparable from quality, safety, person-centeredness in delivering public health interventions and medical care. And I think we all know that the COVID dark cloud that we've been under has been very difficult and has a sad silver lining. The public health cost of massive inequities is recognized by more members of society and leaders than ever before. It's hard to know that it took a pandemic to make visible what had been happening for many years, but that's the case. So that's the sad silver lining. Unfortunately, getting to the point of having health equity requires a deep understanding and actually massive change as well. So this session is all about probing how this pandemic moment in our history can give us a chance to understand better the relationship between inequities as exposed in the pandemic, and with our focus on diagnostic processes and structures that are shaping everything that happens to people as they go from a concern or a symptom to engaging in some way in their own care to understand what might be going on, what the explanation that could be actionable is, and then leading to the outcomes. So I just put that diagnostic process in the structure of everything around it again for us as we enter this particular session, where we're aiming to understand exacerbations of inequities during the COVID-19 pandemic and the types of lessons that could be motivated by what's been going on and could lead us to changes that are needed to improve the diagnostic process and its outcomes for every single person, especially those experiencing the highest level of health harms during this pandemic. That's what this session is focused on, and we will be hearing from four fabulous members of this day and speakers. Dr. Utibe Essien, who is Assistant Professor of Medicine at the University of Pittsburgh and a general internist and health disparities researcher in the VA Pittsburgh Center for Health Equity Research and Promotion, will describe for us structural racism in the healthcare system and its impact on patient behavior. Then Dr. Chow Trin Chevron, Professor in Population Health and Medicine at New York University's Langone Health, will describe the impact of the COVID-19 pandemic on health inequities for different communities. Following that, Dr. Adrienne Biguet, Senior Advisor for UCSF's HEAL Initiative, a Global Health Equity Fellowship, and a family medicine physician on the Navajo Reservation, will provide strategies for addressing health inequities in Indigenous communities during the COVID-19 pandemic. Finally, Dr. Monica Webb Cooper, Deputy Director of the National Institute on Minority Health and Health Disparities, will provide strategies, including national ones, to mitigate disparities in COVID-19 diagnostics. As you know, there are bios available on the workshop website, which provide much more detailed backgrounds on our speakers today. So with that, let's start the presentations with Dr. Essien. Very much looking forward to hearing from you, and then we'll go from speaker to speaker.
Excellent. Thank you so much for that introduction. My name is Utibe Essien, and my talk will be on justice for all, structural racism, and the COVID-19 pandemic. Next slide, please. I have no disclosures to share. Next slide. And so briefly, I have about 10 minutes before I get to pass on to my colleagues. I'll be sharing these three objectives: describing the data related to the COVID-19 inequities, describing the drivers of those inequities, and then lastly, briefly touching on the strategies that we can use to address these inequities and the broader inequities within our healthcare system, as my colleague, Dr. Hooper, will be really expanding upon those during her session. Next slide. Today, we're about a day away from the anniversary of Dr. King's birth. And this weekend, we'll be celebrating his legacy. And this quote is one of the most popular ones that are described when touching on his legacy around healthcare. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Next slide, please. Because of that quote, which easily could have been shared in a newspaper headline last year or the year before that, it really didn't surprise many of us working in the health equity space when the COVID-19 race and ethnicity data started to slowly trickle in. You likely all saw some of the headlines on your screen here, from Milwaukee to New Orleans, St. Louis to Chicago. Racial and ethnic minorities, and in particular Black Americans at the start of the pandemic, were really the most commonly infected, hospitalized, and the most common to die from COVID-19. Next slide. As other national headlines suggested, this issue was, of course, not just a Black and white issue, as Latinx Americans were being affected at higher rates, as well as American Indian and Alaskan Native individuals, as these two headlines show. We know that certain groups from Asian ethnic minority groups were also experiencing higher infection rates at the peak of the pandemic. And as the next slide will demonstrate, those higher rates, unfortunately, resulted in higher rates of hospitalizations. So here we see in some of the latest data by the CDC at the end of last year, demonstrating the higher rates of hospitalization in individuals coming from racial and ethnic minority backgrounds. And again, a lot of this conversation workshop today is about diagnosis. And we know that you have to end up in getting an actual test to be able to be hospitalized and to be able to really see, as we are demonstrating on the next slide, please, the inequities in death. And so unfortunately, we know that some of the age-adjusted results suggest higher rates of death within racial and ethnic minority backgrounds. And so this really provides the background for the story, the background for why we need an hour session on structural racism, health equity, and the COVID-19 pandemic in a workshop like this. Next slide. And my task really is to try and bring the relationship between the structural factors, structural inequity, structural racism, and why those numbers that we just described existed. And so I plan to, on the next several slides, discuss how the pandemic has really ramped up our attention to health inequities and to structural racism, describing risk factors, access to care, missed care, and what the world may look like in the post-COVID era. Next slide. And so we'll focus on this risk factors part of this framework. Next slide, please. Early on in the pandemic, as the data started coming in from China and in Italy in early February of 2020, almost 2 years ago now, we quickly learned that some of the drivers of severe infection from COVID-19 were chronic comorbidities, hypertension, diabetes, obesity, chronic pulmonary diseases. Next slide. Unfortunately, we know in the US that individuals from racial and ethnic minorities are more likely to hold these chronic conditions. And so again, while we suspected that older individuals would be more likely to have severe disease, many of us in this space were also worried that individuals from these communities would be at the highest risk of severe infection because of the disproportionate rate of chronic comorbidities within these communities. Next slide. We also know, unfortunately, that it was not just about comorbidities. And again, it really was the structures in place within where racial and ethnic minority individuals live. Not just where they live, but also even just the very work that they have. You know, this ability to be able to work from home, be on a Zoom call like we are on today, was not afforded to many of our neighbors over these last 2 years. And so these individuals were overexposed to the risk of infection, having to show up to work every single day. They were overexposed through the neighborhoods that they lived in, which may have been more likely to be polluted. And really that, I believe, is a significant driver of the social risk that was causing higher rates of infection in these communities. Next slide. And so as we think about the risk factors, we also have to think about access to care. And that is, we'll discuss on the next slide, where we know that as our friend moves up to the next step here, and the next slide, please. We know that despite the efforts being made nationally, policy level efforts to reduce the rates of uninsurance in our country, that there still remain about 30 million individuals who are uninsured today. And as this slide demonstrates, those individuals tend to come from racial and ethnic minority backgrounds. And so when the first set of news headlines suggested that individuals ask their doctor about their symptoms, well, what does that ask look like for these folks who did not have a single doctor to be able to attend to their concerns or worries about the pandemic? And again, I believe access to care was a big driver of these inequities. Next slide, please. So as we move up from access, if we click on to missed care, on the next slide, we start to examine where all the heart attacks have gone. So this was a headline from one of our colleagues, Dr. Krumholtz, in the early pandemic, who asked, what happened to the non-COVID related conditions that we were typically caring for in the hospital, whether it was cardiovascular disease, liver diseases, kidney diseases? Those seem to have gone away. Obviously, that they did not just disappear. Individuals were no longer having heart attacks or strokes. Unfortunately, folks were too fearful to show up to the hospital for risk of catching or being infected by COVID, or they didn't have the opportunity, again, virtually to connect and communicate with their physicians to be able to have those conditions assessed. And so again, missed care is not only driving issues around COVID-19, but it's also driving our concerns as we move towards a post-COVID-19 era, as we go on to the next slide. And so what does that era look like? On the next slide, we see that it really does focus on these structural factors, these social determinants of health. And so whether it's the education of our community members, their economic stability, or the very neighborhood that they live in, these factors were all where individuals live, work, and play. We're all driving their risk of COVID-19. We already talked about that a little bit more. On the next slide, we see some of the headlines, again, that came up over the last several years, couple of years of the pandemic. Individuals struggling with food insecurity, with housing insecurity, whose risk of these social troubles were putting them at higher risk of COVID-19, whether related to obesity or having to spend time in shelters or locations of higher risk for COVID-19. Again, if you were to look through the numbers, you are unfortunately going to see that individuals from racial and ethnic minority backgrounds are also more likely to have these untoward social determinants of health. And so as we move on to the next slide and the next subhead of this part of the workshop, we start to identify strategies. On the next slide, I'll just mention a few that I want us to touch on. But again, this is an area that Dr. Hooper, our last speaker, is really going to reflect on. So first, we have to think about enhancing data collection. I showed you some of the data from the newspaper headlines earlier on in the pandemic, and that's because it really took some time for us to be able to rev up collection of race and ethnicity data. And so I think that's an area that we must focus on, especially and to learn from post-pandemic. Next heading here is expanding access to healthcare. I mentioned the individuals who are uninsured, but of course, I believe we have to think about access beyond just insurance, but whether individuals literally can show up, can make it to their doctor's appointments. Improving that is key. And the next step is equitable testing and treatment. My research is focused on pharmacoequity, on ensuring that all patients have access to the care that they need. And this is a critical area that we need to address as we're moving on to newer therapies for the pandemic. On the next slide, really this entire workshop that we're going in is on focusing on eliminating racism and discrimination in health and healthcare. And that's an important area, of course, of focus. And lastly, this last E that I'll touch on is elevating our community and social service investment. And I think that if we addressed all of these strategies, that we really can move on to achieve a world that's without structural racism within our COVID-19 pandemic and beyond. And so thank you so much for your attention, and I look forward to learning and connecting with our other speakers.